So I'm Dr. Trepane. What we talk about in these lectures actually, I think, sets the groundwork for a lot of the other lectures that you'll have throughout the coming week. There's a piece of genetics buried within everybody else's subspecialties. So use this as a springboard for listening to everybody else because the genetics will show up in everybody else's. All right, so to get started, we're going to do an overview of genetic disease. We're going to talk about types of genetic disease with selected examples of each, so chromosomes, Mendelian disorders, atypical inheritance, and multifactorial. And then we're going to switch to what it looks like in clinic. How do people actually come in and see you? So we're going to go through medical school and then go to clinic. All right, so impact of genetic disorders. It's the single largest cause of mortality in the 0 to 5 age group. And about 2 to 3% of all newborns have at least one major congenital anomaly. And 2% of all newborns will have a chromosomal abnormality or a single gene disorder. So just a brief rundown of things that are fairly common, from Down syndrome, sickle cell anemia, cystic fibrosis, cleft lip and palate. Congenital heart disease occurs in about 1% of the population, with the most common being VSD, neural tube defects. When you average all of those together, you're up to about 2 to 3% of the population, or of newborns, I should say. So when should you suspect a genetic disorder? I'm a geneticist, so always. But specifically, previous family history. So if a family comes in and says, we have a family history of, take note, they probably didn't make that up. If the parents are related in any way, and I just moved from Iowa, and we have a very large Amish population, so if you have Amish and Mennonite, but there are other populations around the world that will know how they're related to one another. If a family has had multiple miscarriages or in utero death, multiple congenital anomalies, if you have multi-organ dysfunction, any type of neurologic symptoms, and any type of developmental anomalies. So when we talk about our congenital anomalies or birth defects, you should think about genetic conditions if you have 3 or more minor malformations or 1 major malformation. So examples of minor malformations are things like tooth-3-toe syndactyly, if your eyes are too far apart, hypertelorism, preauricular tags, or epicanthic folds. So these are things that don't bother you but are off the beaten path from what we would consider normal. And many of us will have at least one minor anomaly. And this is usually when people start like looking at hands and feet and all sorts of fun stuff. Major anomalies, however, are something you have to do something about. So things like cleft lip and palate, congenital heart defects, brain anomalies, omphalocele, if you're missing a limb. So those are your major anomalies. So again, you distinguish the minors from the majors based on how it affects your overall health. And if you have at least 3 minors, then you're highly suspicious that there's something going on genetically. All right, so types of genetic disease. Well, we're going to start with the chromosomes, and we've now taken to calling them copy number variants, or CNVs. These include our trisomies and monosomies, deletions and duplications, and microdeletions and duplications. We'll talk about single gene disorders, and then atypical patterns of inheritance. All right, so this should look familiar to everybody. These are your chromosomes unwound into your DNA. We have 46 chromosomes. They come in pairs, so there are 23 pairs. The first 22 are autosomes and are the same between men and women. The last are sex chromosomes. And is this a boy or a girl? It's a boy. Excellent. So it's an X and a Y. You guys are awake. The coffee is working. All right, so chromosome analysis is also known as a karyotype. We usually get it from the peripheral blood. It takes about 2 to 4 days to come back, and we're looking at the chromosomes in the white blood cells. If you need a more rapid turnaround, you can do bone marrow. If you've got severe birth defects, you think the baby's going to pass away, or if you're looking for cancer, then we often will get bone marrow biopsy for that. Prenatally, you can do amniotic fluid or chorionic villus sampling. All right, so we're going to talk about big chromosome problems, the aneuploidies, so the trisomies and 1 single monosomy. So an aneuploidy just means you have an abnormal chromosome number. When you have an abnormal number, then you usually have physical findings and developmental delay. Monosomy is a loss of a chromosome, and we only have one of those to remember, which is Turner syndrome. It's 45X. If you learned it 45XO, there is no O chromosome. So we've gotten rid of the O as a placeholder. It's just 45X. Trisomies, you can do trisomies of almost anything, but the ones that we will see most commonly and get tested on are Klinefelter's, Downs, Edwards, and Patau's. Your risk factor for aneuploidy is increasing maternal age. So if you're under the age of 35 and you've had a child with a chromosome imbalance, we give you a 1% increase over your age-related age. If you're over the age of 35, you just keep your age-related risk. All right, so Down syndrome, trisomy 21. This is the most common chromosome disorder in live births, and it occurs roughly in 1 in 800 live-born babies. Most of us can pick people out of the crowd with Down syndrome fairly easily. We can recognize the facial features. They have a short head from front to back, low set, small ears. If you have an ophthalmologist and they have light-colored irides, you can see the brush field spots. They'll have short stature, short hands with a single transverse palmar crease. Half will have a congenital heart disease. So common things are common even in uncommon disorders. So the most common heart defect in the general population is a VSD. So the most common heart defect in Down syndrome is a VSD. However, if you say the words AV canal defect, that gets everybody's attention because it has a high correlation with Down syndrome. Does that make sense to everybody? Okay. Duodenal atresia in about 12%, leukemia in less than 1%, but higher than the background risk in the general population, Hirschsprung's, and then intellectual disability that's variable, usually on the average of mild to moderate. Some people will tack a little high, and then some people will actually have severe to profound mental or intellectual disability. Most usually due to free trisomy 21. So rather than 46 chromosomes, you have 47. So here you can see with the nice arrow that there are 3 copies of chromosome 21. And that's about 95% of the time. About 4% of the time, it's a Robertsonian translocation. So you have 46 chromosomes, and this extra 21 is hooked to another chromosome, like chromosome 14. There's no difference in the clinical presentation of these people. The only reason why you want to know this is for the parent's recurrence risk. And about 1 to 3% will have mosaicism, so they'll have more than one cell line. And they can be mosaic with a normal karyotype, or they could be mosaic, I've had it with Klinefelter's, so multiple aneuploidies in the cell lines. Again, free trisomy 21 increases with increasing maternal age. We would presume with increased age it's free trisomy 21, but we still get a karyotype to make sure that it's not this translocation. All right, so here's the Sandel gap that we can see. It's fairly common in the population. So there's no one single thing on the list for Down syndrome that is pathognomonic. It's putting the whole picture together. About 10% of the population will have a single palmar crease. So that means there should be several floating around in here. About 1% of the population will have it on both hands. But if you look at a population of children with Down syndrome, about 70% will have a single palmar crease. You can see the hypotonia with the open mouth, the epicanthic folds. Often in the brand newborn at rest, the facial features are not as striking until I make the baby cry. And it's this grimace that sort of brings out the facial features. Again, can have myopia. Here's the low set, squared off small ears, and an epicanthic fold. All right, so the other 2 autosome aneuploidies are trisomy 18 and 13. So trisomy 18 is Edwards, trisomy 13 is Patau. Here's your extra 18, here's your extra 13. Trisomy 18 is about 1 in 8,000 live births, and trisomy 13 is more rare at about 1 in 25,000. Both are more frequent in pregnancy losses. So even with Down syndrome, there's a high rate of fetal loss whenever you have an aneuploidy, but much higher with 18 and 13. So 95% will not reach term. The statistics vary, but on average, it comes down to about 80% will have a full trisomy, and 20% will either be the mosaics or translocation. So again, you may recognize what the condition is, but the reason why you get the karyotype is then to tell the parents if this was a sporadic condition or if they have an increased risk for recurrence. For trisomy 13, a translocation between 13 and 14 is common. If the parents have normal chromosomes, there's about a 1% recurrence risk and only about a 2% risk if one of the parents is a translocation carrier, and that's simply because of the high rate of fetal loss. So both of these have poor prognosis. Usually they die in the first months of life due to aspiration, apnea, or a very severe heart defect. So 70% by 3 months, 90% by a year for trisomy 18, and 95% by 3 years for trisomy 13. They have multiple malformations, and these are the same pretty much between the two. They're small for gestational age. They have this hand clenching and overlapping fingers, rocker bottom feet. Heart defects, intestinal atresias, and cleft lip and palate can be seen in both, but is more common in 13. Unique to trisomy 13. So if you're reading through a vignette or you're seeing a baby and it sounds like a 13 or an 18, the things that you're going to look for are holoprosencephaly, small eyes or microphthalmia, cutis aplasia, and polydactyly. In those children who do survive, there is profound intellectual disability. They rarely learn how to walk or talk. All right, so here's the characteristic hand clenching with the overlapping first finger and thumb and a rocker bottom foot. If you have an arch, you don't have a rocker bottom. So lots of things come to me described as rocker bottom feet. What they're trying to tell me is the foot doesn't look right, but it really does look like a rocker on the bottom. Over here, you can see the child's hand clenching, very tiny. This is a trisomy 18. It has a cute little button nose that is upturned and these little pointed ears, which is different than this child, which has this broad nasal tip. And even in the absence of clefting, the nasal tip is very broad and widened. And then this is cutis aplasia. All right, first chance to participate here. Parents of a child who died shortly after birth with trisomy 13 and has a karyotype of 47XX positive 13 come to you for counseling about future pregnancies. Of the following, their risk for giving birth to another child who has trisomy is closest to excellent. All right, so we're off to a good start. So it is 1% added to the mom's age-related risk. And these recurrence risks are based on empiric data. So we just keep tabulating and keeping track, and that's where that 1% comes from. All right, moving on to our sex chromosomes. About 1 in 500 newborns have an abnormality of either the X or Y chromosome. 80% are 47 XXX, 47 XXY, or 47 XYY. What we won't talk about are the XXX and the XYY because most of those do not have overt physical findings and are often picked up incidentally while you're working up something else. Turner syndrome, 45X, is most commonly results in miscarriages or stillbirths, and so is only about 1 in 2,500 live births. We think the conception rate is the same for the other sex chromosome aneuploidies, but they just don't make it to being born. All right, so we'll start with Turner syndrome, and again, 45X, this person has an X chromosome and is missing the second. Mosaicism is common, so they may have 2 cell lines, and it can be 46XX or it can be 46XY. And that's important to know, because if you have a 46XY, then you have to look at the gonads, and they have an increased risk of malignancy in those gonads. Again, high rate of fetal loss. Clinical features, nuchal webbing, puffy hands and feet, coarctation, short stature, they're infertile, with gonadal dysplasia. The only consistent finding in women with Turner syndrome is short stature. Everything else is variable. There's only 3 ways that I've met people with Turner syndrome in clinic or on a board exam. So this is where your board exam and clinic look exactly the same. It's either a baby who is puffy and has a coarct, it's a child who is not growing well and has short stature, or it's a girl who has delayed onset of puberty. And this is also the one that is not related to maternal age. So Turner is unique in 2 different ways. It's the only monosomy, and it's the only one who is not related to maternal age. All right, so here's the puffy feet. Here's the increased nuchal folds and webbing. And the more of this webbing you have, the more it's more correlated with having the coarctation. And here you see what it looks like on an older child. Klinefelter is 47XXY. Can be confused with Marfan. I've probably picked up more Klinefelters in my Marfan's clinic than in any other place because they get referred in for their tall stature and kind of lanky body habitus. They have small testes and are infertile. They can have gynecomastia. They may have learning and behavioral issues. It may not be apparent easily if they're from a very high-functioning family, but they usually do not have the IQs that the family has, but that still may keep them clearly in the normal range. You can also have more than 2 X chromosomes. So I always think of 2 X chromosomes as being a good thing. If you're a Klinefelters, it's not. So when you have a Y, having 1 X is not good. Having more X's is not good. The more X's you have, the more neurologic problems you have, and then you end up with intellectual disabilities, behavior disorders. All right, so those are our big things. Those are the things that you can pick up on a chromosomal analysis or a karyotype. The next set of deletion syndromes that we'll talk about, you can still pick up on the chromosome test itself. And these are old deletion syndromes. And the 2 that you get asked about on exams are Wolff-Hirschhorn and Creta-Shaw. But be aware that this can occur on many other chromosomes, and here's just a partial listing of ones that are more common. All right, so Wolff-Hirschhorn is also known as 4p- syndrome, and Creta-Shaw is known as 5p- syndrome. So as stated, Wolff-Hirschhorn is due to a partial deletion of the distal P arm of chromosome number 4. So P is on the short arm or petite arm, and you're missing almost a good chunk of the P arm. And so you'll be able to see that on a karyotype. Creta-Shaw, you're also missing this distal P arm of chromosome 5. 85% are de novo for both. 15% will have a parent that has a balanced translocation. So again, making sure we go back and grab parental karyotypes when we see a child with one of these 2 conditions. Wolff-Hirschhorn has this Greek helmet facial type. There's a very prominent glabella or mid-face between the eyes. And they can have clefting. Creta-Shaw is defined by its cat-like cry. In the neonatal period, it often goes away in the first months of life. So what you'll get is the parents bringing in, now with their cell phones, audio of the child crying. And they can also have wide-set eyes. Both have poor growth with microcephaly, heart defects, and severe intellectual disability. All right, so moving even smaller, in the 90s, we began to find deletions that were below the resolution of the karyotype. The ones in pink here, we're going to talk about here. We're going to pick up the other ones when we go to clinic in different groupings, okay? So we're going to talk about VCFS, velocardiofacial syndrome, or DeGeorge syndrome, and WAGR, W-A-G-R. The way we pick these up are with a technology called FISH. And with FISH, we can see below the resolution of the karyotype. So these are not cytogenetically visible. They take out a section of genes, and then you get a compound phenotype based on that. So with the FISH, you can see over here, and geneticists always forget that people have red-green color blindness, so all of our probes are in red and green. So this is a normal number 7, so there's a red on one end and a green on the other. On this one, there's only green probes. So we're missing one end and got the other end replaced on there. So 3 of one and not one of the other. So we have these probes, and you have to know what you're fishing for. So you have to be able to tell the cytogeneticist, this is what I think. You can't just order a fish. The lab will call you back and ask, which one do you want? Because they are very specific to each of those chromosomal areas. They can get down to 100 to 300 kilobases. On a karyotype, one band is about 8 megabases or 8,000 kilobases. So this is far below the resolution of that karyotype. Normal is 2 signals. A microdeletion, you will get only 1 signal back. If it's not there, the fish won't bind to it. So an example of this is 22q microdeletion syndrome. Again, the reporter probe is in green, and then the particular fish is in red. So here we have a green lighting up here and a green lighting up here. That tells us this is chromosome number 22. And then the red is present on this one, but it's absent here. So we know we're missing that piece of chromosome 22. People with 22q deletion syndrome, with about 15 years or so ago, we tried to rename it as Catch-22. It did not catch on. But it does serve as a helpful mnemonic. So cardiac defects, particularly conotruncal defects, abnormal facial features, T-cell deficits, cleft palates, and hypocalcemia. So there's another condition out there that will give you hypercalcemia. So if you've got calcium thrown into your question, know that if it's too low, you're thinking about 22q. If it's high, you're thinking about Williams. So other names for 22q microdeletion syndrome are DeGeorge syndrome, velocardiofacial syndrome, Spritzen syndrome. So before we knew the etiology of this condition, we thought we were being smart and naming subsets. It turns out all of these people have exactly the same thing with the same deletion. So variable clinical presentations, even in the same family. So congenital heart defects may or may not be there. Intellectual disability, behavioral and psychiatric problems, clefting, thymus and parathyroid hypoplasia, which leads to T-cell problems. We will talk about in the next lecture newborn screening. So some places have started doing screening for SCID. Some of our 22q deletions will get picked up on that newborn screening. And there's this tubular-shaped boxy nose. So that's what this is showing, that the nasal bridge is wider than it should be, and it looks more rectangular or boxy than it should be. So your nose should be a nice triangle. If you sit and look at your partner on your desk and you look at their nose and it looks nice and triangular, right? But if it's straight up and down and looks more like a rectangle, then you think about this condition. So any person who has congenital heart defects and learning problems, you should think about 22q. WAGR, W-A-G-R, is an acronym that tells you exactly what we're looking for. This is also a contiguous gene syndrome due to a deletion on 11p13, and it includes the WT1 gene. So there are some people in the world who don't have the deletion but have an actual mutation in WT1, which will also give you the risk for having the Wilms tumor. So Wilms tumor, aniridia, GU malformations like hypospadias or cryptorchidism, and the R used to stand for mental retardation. That's been turned into intellectual disability. So it comes just as billed. So now we've moved on to doing chromosomal microarrays. There are many different new syndromes that are being elucidated every single day. They will not make it to your board exam. They will make it to the genetics board exam. So if you know the ones that we've already listed, then you'll be fine. But in the context of doing clinic or in how to do a workup for someone, you need to know about chromosomal microarray. It's also called comparative genomic hybridization. And this is where the term copy number variants come in. So it detects gains and losses, so the old-fashioned duplications and deletions, down to 1 to 5 kb. And that's smaller than the karyotype, which was 5 to 8,000 kilobases, or by fish, which was 300. So if you can see it on the karyotype and you can see it on the fish, you'll see it on your microarray. So you can pick up 22q and Wager on a microarray. So if you weren't sure what you were looking for, you didn't know which fish to order, and you got the microarray, you would still pick up those conditions. However, what it does not do is detect rearrangements or the location of extra chromosomal material. So we always know where the deletion is because it's absent. But if you've got extra material, it just tells you you have extra material. It doesn't tell you where it's located. So you're still going to need either a karyotype or a fish to be able to locate the extra material. This has now become the first-line test for people with intellectual disability or autism, especially when it is non-specific. They're not dysmorphic, or they're dysmorphic, but they're not speaking to you in a way that says, I think this is Wolf Hirschhorn. This is not Williams syndrome. This is, I don't know what this is. So now we can use this as our first-line test. And we also use it for children with multiple congenital anomalies. All right, 15-year-old girl comes to your office because she's never had a menstrual period. Mom and sister both had menarche at 13. She has no chronic illnesses. She's active, plays softball once a week. Physical exam, she's at the 5th percentile for height and weight. She has no hirsutism or acne, no breast development, and sexual maturity rating, what I learned is Tanner staging, is stage 3 pubic hair development. Of the following, the most likely cause for her delayed menarche. Excellent. This is truly the classic question for Turner syndrome, or one of the 3 classic ones. So this is delayed onset of puberty. She's not having any signs of virilization that would make it CAH. It's not Klinefelter because those people are male. Primary hypothyroidism could give you delay in your puberty, but wouldn't explain the absence of breast development, and the anorexia also would not be consistent with what we were seeing. All right, now we're going to make a switch to the single gene disorders. For Mendelian inheritance, we're going to do dominant, recessive, and X-linked. We are not going to do P's, but you will see Punnett squares. All right, so when you have an autosomal dominant condition, one mutant allele is sufficient to cause your disease. It will affect multiple generations. It affects both sexes equally, and there's male-to-male transition. So often they will give you a vignette that gives you all sorts of information, and you think you have to figure out the disorder, but really what they're going to ask you is, how is this being transmitted, or what is somebody's recurrence risk? So once you have it, you have a 50-50 chance of passing it on to your offspring. So here's the Punnett square. The A is abnormal. You either give away your big A or your little a, 50-50. Classic examples: Alagilles, achondroplasia, OI, charge. We'll also talk about later in F1 and Marfan. What we won't talk about is most of our familial cancer syndromes are dominant in nature. All right, so Alagilles. Autosomal dominant due to a mutation in JAG1 or Notch2. It can also be due to a microdeletion on 20p12, which includes the JAG1 gene. Clinical features include paucity of the bile ducts, cardiac defects, primarily peripheral pulmonic stenosis, eye abnormalities that include posterior embryotoxin and a prominent Schwalbe's line, so we need the ophthalmologist coming in and doing that slit lamp exam for us. They can have skeletal features like butterfly vertebrae, and they have particular facial features that include a prominent forehead, deep-set eyes, and deep-set and wide-spaced eyes, or hypertelorism. They have this pointed chin that you can see right here, and a bulbous tip of the nose, so a little more full at the end. Right, achondroplasia. There will always be a dwarfing condition on the boards. So really what you have to know is whether or not it's achondroplasia or not achondroplasia, as achondroplasia is the most common dwarfing condition. There's over 100 of them, so you won't get asked on all 100. It gives you a disproportionate short stature, and it's a short-limbed dwarfing condition. So the trunk is normal size, but the arms and legs are short. It's rhizomelic limb shortening. So rhizo means root, which means it's the part closest to the body that is the most short. So we do dwarfing conditions or bone dysplasias by rhizo, meso, and acro, or your hands. So it tells you which part is the most affected. All will have macrocephaly. Most will have absolute macrocephaly, not just a big head for their height, but will be off the chart despite, for anybody. It's 100% penetrant, which means if you have the mutation, you look like you have achondroplasia. Nobody's going to scoot by without you noticing. It's due to a mutation in FGFR3. There is a paternal age effect. So women have an increasing risk of having children with chromosome abnormalities with age. Men have an increasing risk of having a child with a new onset autosomal dominant condition as they get older. And this is one that is particularly affected, are the FGFRs and achondroplasia, among others. High new mutation rate. So 80% of them will be first in their family. Nobody else has had it, and the parents are unaffected. But because it's dominant, once you have it, you have a 50-50 chance of passing it on. There is a health supervision guideline from the AAP. If there is a health supervision guideline written by the American Academy of Pediatrics, the likelihood of that disease being on your board exam is increased. Not guaranteed, but high yield. All right, so we can have sporadic cases with these autosomal dominant conditions where neither parent are affected, and the new mutations occur with varying frequency, and it depends on the disorder, the reproductive fitness, and the gene size. So if you have a low reproductive fitness, which means you don't grow up and pass on your genes to the next generation, you have a much higher chance of that being only introduced as a sporadic new mutation. If you have a high reproductive fitness, then you have a much lower sporadic component to that. So like Marfan syndrome, many people don't know and don't get diagnosed until mid-adulthood, after they've had kids. So you have a high reproductive fitness, much lower sporadic contribution. So the more severe the disorder, the more likely the new mutation. There's implications for recurrence risk. So if you have it, you have a 50-50 chance of passing it on. But if you're the parents who have the sporadic condition, it is unlikely, but not impossible. You never say never, and you never say always. All right, so once you have achondroplasia or a variety of other autosomal dominant conditions, if you have a child with somebody else who is similarly affected, the homozygotes for the mutation are then much more severely affected than either parent. So two parents with achondroplasia have then a 1 in 4 chance of having a homozygous affected child, and that's perinatal lethal. So here you have on the Punnett square, one parent with achondroplasia with the big A, the other parent has achondroplasia with the big A. 1 out of 4 chance of having a child with this lethal double dominant. They also have a 1 in 4 chance of having a typically heighted child. They can both give the non-mutated copy. All right, other autosomal dominant conditions include osteogenesis imperfecta. This is a disorder of type 1 collagen due to mutations in COL1A1 or 1A2. Germline mosaicism has also been reported. So not just sporadic new mutations, but also germline mosaicism. There are 4 main types of osteogenesis imperfecta. We keep discovering newer ones. The newer ones that we're discovering are far more severe and will not be on your board. So these are the ones they're going to test you on. They range from mild to lethal. Type 1 is the most mild. Type 2 is lethal. 3 and 4 are variable. Clinical features include osteopenia and multiple fractures. So we get called for the non-accidental trauma evaluations to make sure it's not this. Short stature. There'll be scleral hue changes, and this can be difficult in fair children with blue irides, and it may take some time for children without OI to clear that nice little blue scleral hue, but that can be one of our clues. Some will have dental problems as well, and then they're at increased risk for hearing loss. Charge syndrome is generally sporadic. There are rare germline mosaicism due to mutations in CHD7. And this is another one of these acronyms. So if you know what the acronym is, then you know what you're looking for. So the C is colobomas, H is heart defects, A is choanal atresia, R is retardation of growth or intellectual disability, GU abnormalities, and ear abnormalities or deafness. So often we get called when somebody sees a coloboma, but more often when somebody gets choanal atresia and you can't pass the NG tube down. And then we begin this workup. All right, so this germline mosaicism can occur when there are multiple children affected with an autosomal dominant condition and the parents are clinically normal. So we told you this shouldn't happen again, and it keeps happening. So you can see this woman had 2 children with lethal OI with one partner and 1 child over here with another partner. And unless these 2 people are related, that seems very odd. And then here's 2 people, a couple with 2 children with achondroplasia. So rather than the children having achondroplasia or a mutation in every gene in all of their cells, one of the parents has a mutation harbored in either the egg or the sperm and is unaffected because it's not in the rest of their body. But they can keep having this occur over and over again. And we do empiric studies and to find out what your germline mosaicism rate is for different dominant conditions, and it varies across the conditions, but can be as high as 3 to 4%. So that's why we never say never. And again, the recurrence risk then depends on how high the proportion is in those gametes. All right, recessive conditions. Now you need both copies of the gene to cause the disease. Males and females affected equally. The heterozygotes or carriers are clinically normal. So you just see these lonely 2 people here on the pedigree with the condition. One of the questions that will always get asked is if you are the unaffected sibling of somebody with a recessive condition, what is the likelihood that you are a carrier for that condition? So, and the answer is 2/3. So here are the parents who are both carriers. Here's the affected sibling. So if you know you're unaffected, you only have 3 boxes left. 2 out of those 3 boxes are carriers. When the parents are planning a next pregnancy, they have a 50% chance of creating a child that is a carrier. But if you're already here and we know you're unaffected, you can get rid of one of these boxes. And then you increase to 2/3 chance of being a carrier. So examples of recessive conditions include cystic fibrosis, the hemoglobinopathies, and most inborn errors of metabolism, which we're going to do in the second 2 hours. So one of the things that we ask about when we take family histories is if the parents are related in any way. If you are, then you've increased your risk of uncovering a rare recessive condition. So we ask about the consanguinity. The people that are related by descent from a common ancestor, again, more likely to see with very rare disorders or geographically isolated populations, which means you're more related to each other. And then communities that are isolated due to ethnic or religious beliefs, like my Amish and Mennonite populations. And when we do the inborn errors, there are certain ones that go with certain populations. You may be asked to calculate a carrier rate based on the incidence of the disease in the population. So if you go all the way back to undergraduate biology and the Hardy-Weinberg equation, for a population, p squared plus 2pq plus q squared equals 1. So 1 is 100% of the genotypes. AA, the big A is p squared. Q squared is little a, so the disease in the population. And then 2pq is the frequency of the heterozygote genotype, or the big A, little a. So if they tell you that the incidence of cystic fibrosis is 1 in 2,500, and they will always give you something that has a square root. They're not asking you to do math. They're asking you to do the concept. So then Q squared, or the rate of the disease in the population, is 1 in 2,500. The square root of that is Q, which is 1 in 50. P plus Q has to equal 1, so then we know P is 49 over 50, and for make it simple, that's 1. So your carrier rate is 2pq. So 2 times p, which is essentially 1, times q, which is 1 in 50, gives you 1 in 25. So it's a quick and easy way to calculate what is the chance that somebody is actually a carrier for a disorder in a population. All right, X-linked. Enough of the math, back to pictures. All right, males are usually severely affected and the disease is passed through healthy carrier females. Again, trick questions. Always read the question carefully. This is the easiest way to miss a question or to get it right. A woman has a 50% chance of having an affected son. She has a 50% chance of having a carrier daughter, and she has a 25% chance of having an affected child. So when they ask you the question, make sure you know, are they asking you about a son, a daughter, or a child? Right? Because she can pass on this little a to a boy, and that's 1 out of 4 total possibilities, so 1 in 4 for a child, but half of the boys will be affected. All the daughters, if you have an affected male, all the daughters are obligate carriers. There is no male-to-male transmission. So examples of this are Duchenne's muscular dystrophy, G6PD, and Rett syndrome. In the next hour, we'll talk about OTC deficiency, but also things like hemophilia, and red-green color blindness are on this list. All right, so all of our X chromosomes in women are not active. We turn off one of our X chromosomes, and this is the lion hypothesis. The second X remains condensed and inactive, and this is done at a fairly early stage while we're developing, and is usually complete by about the first week of life. Once that X is inactivated, the decision is permanent. Interestingly, for cats, coat color is on the sex chromosome. So if you have a calico cat, you can tell what sex it is. So what is the sex of this cat? This is a female cat. If, however, you chase down the cat to test your hypothesis and you turn the cat over and it's a boy cat, what's the karyotype of the cat? It's a Klinefelter cat. Ah, these are party tricks that you should know, okay? Because a Klinefelter will have 2 X chromosomes and will get the varying coat color. All right, and we think we do this because of dosage compensation. Men only have 1 X chromosome, so we turn off one of ours to be in all fairness to the men. Best way I got to explain it. But what this does lead to is variable expression in heterozygote females, because we are mosaic for everything that's on the X chromosome. So if you have a mutation in one of those genes on the X chromosome, you might act like a male that's affected. Because if you do a 50-50 split, you'll have enough running around your body of whatever it is you're supposed to be making. If, however, you inappropriately lionize, and let's say you turn off 90% of your good gene and leave on only 10%, then you're going to act like a boy with that given disease. So whether or not we're talking about OTC deficiency, Duchenne's muscular dystrophy, red-green color blindness, then you're going to look like you're actually affected with that X-linked condition. All right. You'll cover Duchenne's again with neurology, but just very briefly, it is a muscular dystrophy. It is progressive, onset in early childhood. They become non-ambulatory by their teens. About a third will have cognitive delays, and they have an increased risk for cardiomyopathy. There are mutations in the dystrophin gene. The dystrophin gene is huge, so it collects mutations left and right. There's also a high new mutation rate in the child's maternal grandfather. So the grandfather had a mutation in his sperm on the X chromosome, gave it to his daughter. Daughter's unaffected. Daughter then goes on to have affected children with Duchenne's muscular dystrophy. We've also seen germline mosaicism in Duchenne's. G6PD deficiency, the hematologist will talk more about as well. It's X-linked recessive, so for women to be affected, we need both copies to be mutated. It does confer resistance to malaria. And you get a hemolytic anemia when you're exposed to oxidative drugs like chloramphenicol, the anti-malarial drugs, and the infamous fava bean question. If there are fava beans involved, they're asking you about G6PD. All right, Rett syndrome is an X-linked dominant condition. We have seen males with mutations in the same gene, but it's usually very early presentation with lethality. It's due to mutations in the MECP2 gene. The babies start off looking normal. They're normally grown. They're not dysmorphic. And then they begin to slow. So their development slows down and their growth slows down. The microcephaly is not a congenital microcephaly. It's an acquired microcephaly. So they start out normal, but the head begins to slow down. So you watch them crossing percentiles over time. They do this interesting hand-wringing stereotypic behavior. And so if you see somebody who is intellectually disabled and they keep wringing their hands, think about Rett syndrome. They can have seizures, breath-holding spells, and autistic-like features. All right, a 10-year-old girl presents for evaluation of multiple cafe au lait spots, nodules under the skin, severe scoliosis. Family history is notable for a father who has scoliosis and similar spots, a paternal aunt who has had an optic glioma and bone problems, and a paternal grandfather who had joint dislocations and now has a large mass on his back along with spots. So you quickly draw a pedigree. Based on the family history, the most likely pattern of inheritance is excellent. So key to this is there's male-to-male transmission, so you know it's not an X-linked condition. Multiple subsequent generations affected with male-to-male transmission. We're just going to keep re-saying that over and over again. All right. So those are the typical Mendelian inheritance patterns. Now we're going to move to atypical patterns. These things do not follow autosomal dominant recessive or X-linked pattern inheritance. Different mechanisms: genomic imprinting and uniparental disomy, mitochondrial inheritance, and trinucleotide repeats. We're going to start with the most confusing one of all, the genomic imprinting. So you get differential expression of your genes based on which parent you got it from. So typically we say you get half of your genetic information from mom and half from dad. All things are equal. Somewhere in the mid to late 90s, we figured out that that's almost true. There are a subset of areas in your genetic information where you're only working off of mom's copy or dad's copy. And in order to turn those off and on, we call that imprinting. So if you are missing or have a mutation in a gene that's the only copy you're working from, you'll look like you have the disease. If, however, you have a mutation in a gene that is not the copy you're working from, you don't see it. So it's like going to a bunch of these rooms, because we're staying in a hotel, and there are broken light switches in some of the rooms. But if the rooms are never occupied, you don't know that they're broken. But if the rooms are occupied, you know they're broken. So it makes a difference where those mutations are and who you got it from. So in this scenario, Michael has a disease, but you can only see it when you get it from your dad. When you get it from your mom. So when he passes it on to his children, Ann and Tom, they're working off their mom's copy because they never work off their dad's copy. But they still inherited the mutation, but you just can't see it. So when Tom has his kids, again, they're going to work off their mom's copy. So it doesn't make you can't tell the difference whether or not they got it or they didn't. So it looks like it went away over here. However, Ann, when she goes to have kids, they only work off their mom's copy. So if she gives a normal one, she has kids without the disease. And if she gives away the mutation, then they're working off of it. And you see the disease come back. But when you see this on a pedigree, it looks really confusing. Why it goes away, and it can go away for multiple generations and then pop back in because it's still lingering there where it's not being acted upon. So in the late 90s, we discovered that Prader-Willi and Angelman syndrome are due to imprinting disorders. And they're due to deletion, so they're deletion syndromes, but with an imprinting twist. So they're due to deletions on chromosome 15 at Q11 to Q13. And they're differentially imprinted in this area. So if you have a deletion and you got it from dad, then you end up with Prader-Willi syndrome. If you get a deletion from mom, you end up with Angelman syndrome, because they're right back to back are two imprinted areas in that deletion. So they're differentially imprinted. So again, Prader-Willi is due to the loss of the paternal genes, Angelman due to the loss of the maternal genes. There's a number of different mnemonics out there to help you remember. I don't find any of them useful. I have to go back and redo it every time before I go in and counsel people. Prader-Willi gives you hypotonia and poor weight gain in infancy, followed by rapid weight gain at age 2 to 4 years that leads to obesity. And that's a classic in your clinic and classic board exam question. They also have short stature, small hands and feet, hypogonadism, and mild to moderate intellectual disability. The person who trained me describes their mild to moderate ID in the realm of they can still call for pizza. So we have several patients that would steal their parents' credit cards, pick up the phone, call for pizza. So they've locked the cabinets, trying to control their diet. They're savvy. And now it's worse because we have the cell phones and stuff, so. All right, Angelman, much worse clinical presentation. Ataxic gait with jerky arm movements. The older term for this was happy puppet syndrome. That's been retired because people find it offensive, but it does get to the ataxic wide-based gait. They have seizures in this unique behavior with the inappropriate happy demeanor, frequent laughing, smiling, and excitability. They have a small head, deep-set eyes, and prognathism as they get older. When they're very young and toddler age, I don't think kids with Angelman syndrome look different from any other child. And again, severe ID with severe speech impairment. Another condition that goes along with genomic imprinting is Beckwith-Wiedemann syndrome. They may also have autosomal dominant inheritance. These kids are overgrown, so it's one of the most common overgrowth syndromes we have. They can be large for size at birth with the macrosomia, but they can also have a large tongue, macroglossia, these earlobe creases or pits, hemihypertrophy, and omphalocele. They're at risk for hypoglycemia, so treat them like any other large for gestational age baby. And it can be prolonged hypoglycemia, and at the ends of the spectrum, it can last up to several months. They are at risk for embryonal tumors like Wilms tumor and hepatoblastoma, so we have a screening protocol for them as well. All right, so you're called to the nursery to evaluate a male infant at 36 hours of life. He has periorbital fullness, downturned lower lip, iris has stellate pattern, he has elevated calcium level, and an echo reveals a supravalvular aortic stenosis. Of the following, this infant will most likely have excellent. We haven't even done this one yet. So often on test questions, they will ask you a thing that makes you label the thing, right? So rather than just giving you a list of disorders and asking you which one it is, you have to know which one gives you obesity as a toddler and name it, which one gives you Wilms tumor and name it, and then figure out what those correlations are. So each one of these are key terms to look for when you're taking your test. And again, this is Williams syndrome. So, and we'll cover it in the second half of this one. With Williams syndrome, they have this very friendly personality and elevated calcium, and supravalvular aortic stenosis is an attention getter, that particular cardiac defect. Obesity in a toddler, especially after failure to thrive, is Prader-Willi. Wilms tumor with Weger syndrome can also be found in Beckwith-Wiedemann. The cat-like cry is Creta-Shaw, and paucity of bile ducts is Alagille's. All right, trinucleotide repeats. So some of our genes have these triplet repeats in them. So it's a series of 3 bases in the DNA coding for a specific amino acid. And they're normally stably transmitted. But you can get expansion, and it will result in a number of diseases. The size of the repeat then correlates with the severity and age of onset. And the size then is influenced by the sex of the parent that's transmitting it. This is called anticipation. So as these slip to the next generation and they go to an increasing size, the disease looks like it's getting worse with each successive generation. The one that we get tested on the most is Fragile X syndrome. This is the most common inherited form of intellectual disability. So the most common form of intellectual disability, well, the most common genetic form is Down syndrome, but 95% are sporadic. So Fragile X is the most common inherited form. The most common teratogen worldwide is alcohol. The most common virus is CMV. So about 1 in 2,000 live male births will have Fragile X, 6% of males with intellectual disability, and 30% of women who are carriers for Fragile X will also have findings. So intellectual disability, plus or minus some autistic-like features. They have these large ears, generalized overgrowth, tall stature, large head, hands, and feet, and macroorchidism after puberty. And it's due to an unstable CGG repeat in the FMR1 gene. This, again, is X-linked. All right, moving on to multifactorial. This is where your genes and your environment interplay to give you the disease. And it underlies most of our common disorders, things like cleft lip and palate, neural tube defects, congenital heart defects, and in adults, things like diabetes, hypertension, and psychiatric illnesses. When you see something that's multifactorial, usually the recurrence risk for future pregnancies is about 2 to 5%. There are tables that we use to look up for specific conditions. There is this idea of a threshold model. If you have enough genetics and enough environment, then you will then push yourself past that threshold. So if you have very little genetic contribution, you're going to need a lot of environmental contribution to push you past that threshold. If you come genetically primed, you need very little of the environment to push you past that threshold. So things like cleft lip and palate, when we talk about it as a multifactorial condition, cleft palate, remembering it's distinct from cleft lip and palate. So this down here is different than this. Also, a midline cleft is always bad. Like diastolic murmurs are always bad and direct hyperbilia is always bad. You can put this in the always bad category. So if it's a midline cleft, you look for holoprosencephaly. There are some syndromes that have associated cleft lip and palate, and they're both recessive and dominant. But most people who have a straight up cleft lip and palate have a multifactorial form, and it's a 4 up to a 9% recurrence risk. So the more severe the clefting, the higher the recurrence risk we're going to give you because we think you're more genetically primed. So we're going to give you a higher recurrence risk for a bilateral cleft than for a unilateral cleft. If you have multiple family members, we're going to start increasing your recurrence risk. All right. Male infant is born with a bilateral cleft lip. Rest of his physical findings are normal. Family history is normal. And you inform the parents that this is apparently an isolated birth defect. During the counseling about the recurrence risk, about having another child, what would you be most likely to say? And I'll give you a moment to read them before we turn the slide on. And go. Excellent. So I primed you guys well. So because it's bilateral, we're going to give you an increase in that recurrence risk. And again, we range you from 2 to 5% on average, but there are some that have higher risks, like hypospadias can be up to a 10% recurrence risk, and we have to look those up on tables. But if you just remember that 2 to 5%, TAC high if it's more severe, TAC low if it's less severe. All right. Now we're going to go to clinic. We're done with med school. Here we go. So, common findings and syndromes associated with them. Poor growth. Patients are referred for failure to thrive. If you have a known condition and you have a small child, make sure that that child is being plotted on the right growth curve, because many will have their own, and that way you're not comparing them to other children who don't have the condition. So Cornelia de Lange is an excellent example. They do have their own growth charts. It's autosomal dominant. Most are new mutations in the NIPBL gene. They are discovering more genes that go along with it, but that's the one that is the most common. Poor growth, and they'll have intrauterine growth deficiency. They can also have limb abnormalities, and they have these characteristic craniofacial features. What you'll see most often written is synophorus, or the unibrow, which you can begin to see here, but really what gets my attention are these arches on the eyebrows. There's a short nose with anteverted nares, long eyelashes, microcephaly, and a long philtrum. So this is one of the conditions that is on the differential for fetal alcohol syndrome, simply because of the long, flat philtrum. Intellectual disability can be from mild to profound. I've had a young man who was in his high school musical, and I've had people that need total and complete care because they're nonverbal and don't walk. Reflux is also common. So even though they're having small growth, make sure you're treating their reflux, and then they're also prone to having congenital heart defects. Here's the growth curve for weight. So these lines are normal, and the shaded region down here is somebody with Cornelia de Lange. So you can see they can be below the curve and they not the same rate. Limb abnormalities may have short fingers, but may be just completely missing an arm or a leg. They can have syndactyly, and again, here's the synophorus. Hers are not as arched as the other child, but here's this long, flat philtrum and thin upper lip, which mimics fetal alcohol syndrome. Russell-Silver syndrome is another one with poor growth. It's a sporadic condition. About 10% are due to a uniparental disomy of chromosome 7. And up to half is due to an imprinting disorder at chromosome 11p15.5. So this is similar to Beckwith-Wiedemann in the opposite way. So Beckwith-Wiedemann, same area, makes you overgrown. Do it the other way, Russell-Silver makes you undergrown. Small height and weight, they have a normal head circumference. So they look like they have a big head on a little body, but the head is actually the normal size. They have this triangular shaped face. They can have hemihypertrophy, can overlap with NF1 with having cafe au lait spots, but will not be as florid as NF1. They can have a delayed bone age, and again, reflux can be a problem. Noonan syndrome is autosomal dominant due to multiple genes. PTPN11 is the most common. I think they discover 2 new genes every week, but this is the one you would be tested on. Often it is a new mutation. They will present with short stature and characteristic facial features, wide-set eyes, low-set ears, and these down-slanting palpebral fissures. So if you look at this child, from the inner canthus to the outer canthus is going downhill. There's your straight line going across. You can see them going down below that line. You can have lymphedema prenatally and a webbed neck. So if you have a little girl, they sort of look like Turner syndrome, and this used to be called pseudo-Turner syndrome, but it is an autosomal dominant condition that affects both boys and girls. Cryptorchidism and congenital heart disease, primarily in the pulmonic valve. Williams syndrome also can present with poor growth. This is a chromosome problem due to a deletion on 7q11. They also have their own growth charts. Characteristic facial features, this cute little short nose, puffy eyelids, a stellate iris, and a full mouth, and what I would always consider a patulous lower lip. They have intellectual disabilities that tend to be in the mild to moderate range, and a characteristic behavioral phenotype. They are loquacious. If you ever see this word written, they're asking you about Williams syndrome. I don't think I've ever seen it in literature anywhere. I've only seen it on board exams. It is your cocktail party personality. You talk a lot and don't say anything, right? So, and these are the children who do not have stranger danger. If you're doing a toddler exam and they come over and sit on your lap and start talking to you and playing with your hair, you need to reassess what is going on. And then the heart defect that gets your attention is supravalvular aortic stenosis. They can have other heart defects, but this is the one that is the highly correlated heart defect. One more thing. This is the one with high calcium. Remember? And the low calcium was the 22q deletion. Okay. Now on to seeing the 6-year-old female. She's new. She's coming for a preschool checkup. Mom reports that she's always been small. She was small for gestational age, but no reason has been found. She's a picky eater, but otherwise has no other problems. Development is essentially on time, and she's never been hospitalized or had any surgeries. On physical exam, her height and weight are less than the 10th percentile with a normal head circumference, broad appearing forehead, several cafe au lait spots. Otherwise, there are no concerning findings. Which of the following is the most likely diagnosis? Excellent. So Russell-Silver syndrome. So short kid, normal-sized head, otherwise healthy. So we don't have Down syndrome, fetal alcohol syndrome. Notably, 47XXX, the only thing that it's consistently associated with is tall stature, which is why it's not on your boards. Broad forehead, cafe au lait spots, could be NF, but you're really not finding anything else. And in board questions, if they're giving you nothing else, they mean there's nothing else. So don't go looking for it like you would in clinic. All right, bone marrow dysfunction. So these people may have predisposition to cancer or isolated cell line abnormalities. And we'll start with ataxia telangiectasia. It's a recessive condition due to a mutation in the ATM gene. They have an early onset progressive cerebellar ataxia. They have telangiectasias, just like the name says. They can have immunodeficiencies, and they have chromosome instability. So whenever you do their karyotype, their chromosomes just sort of fall apart, and they make all these funny configurations where they're trying to overlap with one another. And they do have a characteristic 714 translocation. If you submit them to ionizing radiation in the lab, they just completely fall apart. And they have an increased incidence of malignancies, particularly lymphatic or lymphoid malignancies. You can get a screening AFP in these kids because that should be elevated as well if this is sort of where you're going with it. Most of these kids will die by their 20s. Bloom syndrome is an autosomal recessive condition due to mutations in the BLM gene. This is a helicase, and we need this gene to maintain genomic stability. So when you look at these chromosomes, they can palisade like this and get connected to one another. And there's an increased sister chromatid exchanges. Overall, they have poor growth. When you can't maintain your chromosome integrity, your overall growth is poor. Failure to thrive with a prenatal onset. They have a telangiectatic erythema and a malar distribution, and, quote, bird-like facial features, so very thin nose and thin midface, and primary hypogonadism. Fanconi anemia is autosomal recessive, and they have 13 genes that have been implicated up to this point. Again, it gives you increased chromosome breakage, so it's part of your DNA repair mechanism. So if your DNA repair doesn't go well, then everything sort of slows down, your body doesn't form correctly, so they can have birth defects that are apparent before we start seeing the anemia part of Fanconi anemia. It is the most common cause of bone marrow failure, and 3/4 will have some kind of dysmorphology. So hyperpigmentation that is not as well defined as the cafe au lait spots of NF1, abnormal thumbs and radial ray defects, short stature, hypogonadism, microcephaly, renal anomalies, and developmental delay. Many of the conditions, many of the features that you'll see overlap with Vactorel. So there's vertebral, there's radial ray problems, TE fistulas, GI atresias, all make me think about Fanconi's as a rule out for Vactorel. And again, back to the anemia part, the anemia is much later coming up in childhood. So you may see a kid with multiple birth defects before the anemia comes on. All right, Black Van Diemen. It's autosomal dominant due to mutations in ribosomal protein S19, and there's 2 other genes that have been implicated. They get a congenital erythroid aplasia. They have anemia. They also have thumb abnormalities. So looking at thumbs is very important. Not having them, having more than enough of them are both problems. So this is a triphalangeal thumb. So when you see a triphalangeal, also think about genetic conditions. Growth retardation, heart failure, and then cradiofacial abnormalities like clefting. Thrombocytopenia absent radius is exactly what it sounds like. It's autosomal recessive due to a microdeletion on 1q21.1, and it deletes the RBM8A gene. Whenever I was in training, we didn't know what caused it. So things do continue to evolve over time. We do discover new genes. The mutation decreases the activity of the gene product and leads to these findings. Hemorrhage is your most serious problem in the neonatal period. The risk is reduced after about 2 years of age. The platelets tend to stabilize at that point. And there's these upper extremity anomalies. So you can get radial ray absence to complete phocomelia. Phoco means seal, and melia is limb. So these are where you have the flippers up at the top. The key here is they always have thumbs in some form or fashion. So even though there's phocomelia going on, you can see there is a thumb structure here. So if you have a complete absence of a thumb, you don't have TAR. So you have to have the thumb. And almost half will have some form of lower extremity anomaly as well. Bruton's X-linked A-gamma globulinemia is X-linked recessive due to mutations in the BTK gene. And it's important for pre-B cell maturation. You don't make plasma cells, so you can't make antibodies. You get recurrent infections with encapsulated bacteria. You don't respond to antibiotics. You get frequent sinopulmonary infections, eczema, and then also vitiligo and alopecia. So you can see the vitiligo here and the eczema. Chronic granulomatous disease, multiple forms, 2/3 are X-linked, 1/3 are recessive. In this condition, your phagocytes are unable to make their oxidative burst, and you get recurrent life-threatening bacterial and fungal infections. So again, these sinopulmonary infections, but different from Bruton's, which you get abscesses, osteomyelitis, and granulomas. You can use an NBT test with a light microscopy or use flow cytometry to be able to pick up this condition. X-linked SCID is severe combined immunodeficiency. It's X-linked. You get a complete lack of T and natural killer cells and non-functional B lymphocytes. So all of your immune function is down, and this is what we're starting to test for on newborn screens. You get diarrhea, coughing, congestion, fevers, pneumonia, and sepsis. So these people go in the bubble. And the original Bubble Boy, this is what he had. All right, a 3-year-old boy presents for evaluation of severe, persistent, and recurrent abscesses in the perianal area. Parents state that he had his first one at about 4 months of age. Parents are also concerned that he has frequent otitis media, sinus infections, and 1 episode of osteomyelitis requiring hospitalization last month. Of the following, the most likely diagnosis is these are confusing, but this is the chronic granulomatous disease. You're looking for the more severe infections than the Brutens. Eczema and recurrent infections can be seen in Wiskott-Aldrich, which may also have the platelet problems, and all the rest have recurrent infections and poor growth. The best advice I have for this grouping is to make yourself a table, so that way you know which keywords they're looking for which condition. But it's the osteomyelitis that gets you on this one. All right, connective tissue disorders. Ehlers-Danlos syndrome. Most are autosomal dominant. There are a few rare types that are autosomal recessive. Multiple genes that are involved. COL5A1 and 5A2, COL3A1, and COL1A1 and 1A2, and then tenascin X. There are several different forms. There's classic, which was the old type 1 and type 2, hypermobile, which is the old type 3, and vascular, which is the old type 4. Those would be the ones that would be on your board exam. But there are a whole host of others that are very rare, like kyphoscoliotic, arthrochalasia, dermatosparaxis, and the list keeps going. All of them will have some form of loose joints. They can have fragile and small blood vessels, small and medium types of blood vessels, abnormal scar formation and wound healing, this soft, velvety, stretchy skin. This person should stop doing this. His face will stay like that, just like his mom said. The skin is stretchy, so the more you stretch it, the stretchier it becomes, and it doesn't necessarily go back to the way you would want it afterwards. So if you see children or their parents, because it's dominant, that are doing this, tell them they can stop showing people, because some people think these are really cool party tricks. And that's also a question I ask people in clinic. Do you have party tricks? And you think to yourself, how do people know that? But I bet you everybody in here knows what their party trick is. So we can all do something fun, whether or not it's wiggling your ears or doing that. Also, easy bruising can be a part of this. The easy bruising, you have to really bruise a lot for me to get my attention. And I'm speaking to a room full of pediatricians that every mother thinks their child has easy bruising. It really has to rise to a level that's different than typical bruising of childhood. All right, so how do you know if you're hypermobile? This is the audience participation part. If your fingers can go past 90 degrees, and you have to hold your hand flat, there's no flying hands, hand flat, pinky up. The next one is, so you get 1 point for each joint that you can do the trick with. Thumbs to your forearm. Elbows that go past 90 degrees. So you can get a little hyperextension, but you really have to go past 90. If you can put your palms on the floor, and I've seen 9-month pregnant women do this, just go, oh, and bend over. I've seen 50-year-old men be able to do this. That is always wrong. Check their joints. And knees that go past 90 degrees. So you can see this hyper, especially on the other leg where it's going backwards. But you can also show how your stance changes in this slouch. So if you don't hyperextend your knees, actually your pelvis goes into better alignment and the spine becomes better aligned. So often what you see are people with chronic aches and pains, not necessarily joint dislocations. The classics will have joint dislocations but little pain. But if it's just this joint hypermobility, they can just be chronically achy. More serious connective tissue disorder is Marfan syndrome. It's about 1 in 10,000 people due to mutations in FBN1. 25% are due to a new mutation, as opposed to achondroplasia, where it was 80%. Most are family-specific mutations, so there's no common mutation that causes Marfan. It gives you a defective protein, which is fibrillin. Features will overlap with homocystinuria, so we'll talk about that in the next, after the break. But those people also have a Marfanoid body habitus. Remember that your Klinefelters also can have this Marfanoid body habitus. But homocystinuria is a recessive condition. Marfan is dominant. There are clinical diagnostic guidelines known as the Ghent criteria. Major criteria include dislocated lenses, aortic dilatation, aortic dissection, and a known FBN1 mutation. But here are a collection of other things that you can find: mitral valve prolapse, high myopia. They can be tall and thin. Some of the adults are tall, but they're no longer thin. Scoliosis, pectus deformities, and long fingers. If you have learning issues, that is separate from the Marfan. And if you have learning issues and a Marfan-like appearance to you, it makes you think about homocystinuria and Klinefelters. They revised the Ghent criteria in 2010. I keep saying recently. I guess it's no longer recent. They need to have another meeting in Ghent. I don't know why all of the meetings happen in Belgium, but they do. And I'm never invited. I don't know why. So again, major criteria: ectopia lentis, aortic dilatation, dissection, family history, or a known mutation in FBN1. If you have two of these, then I can tell you have Marfan's. But if you only have one, then I have to do a physical exam, and this is the systemic score. There are a total of 20 points, and you need at least 7 to be positive. The thing that gives you the highest number of points is a positive wrist and thumb sign, which will give you 3 points. But this includes also things like the eye exam, pneumothoraces, and then you can also do an FBN1 mutational analysis. There are AAP health supervision guidelines, and if you go to marfan.org, they have an online checklist for this. So if you have somebody in clinic, you can check them off using that. All right, so here's the long arms and legs. Pectus excavatum, pectus carinatum gives you 2 points, and excavatum only gives you 1 point. About 1 in 400 people have a pectus excavatum without Marfan's. Here's a positive wrist and thumb sign. So when you wrap around for the wrist sign, it has to overlap past the knuckle. And also when you do a thumb sign, the thumb has to go out past the knuckle. So with all of our young boys in particular, I tell them to put their hands up, thumbs in, and fold over. And every boy out there wants to score high on this test, so they will sit there and push their thumbs and try to make it positive. Tell them to stop, just put it in, because if you truly have Marfan's, when you just do this, it will come out the other side. All right, it's late summer, like it is now. It's time for yearly sports physicals. The last patient of the day is a 16-year-old varsity volleyball player. She's 71 inches tall, weight is 125 pounds, blood pressure is 115/74. On physical exam, you find scoliosis and a 3 out of 6 holosystolic murmur heard at the cardiac apex with radiation to the left axilla. Of the following, the most likely diagnosis for this patient: excellent. So we're thinking about Marfan syndrome. And truly, if anybody walks through your clinic and you think about Marfan, just send them for their echocardiogram. You could save somebody's life. Most of the people we think have Marfan's, or we think about it, it's not going to turn out to be that. But you're really trying to catch the one that does, so they get the appropriate treatment. So she's tall. What we don't have here is her predicted midparental height. That would be helpful. But remember, 75% are inherited from a parent. So even tall people in a tall family are suspicious. You might end up diagnosing more than one person. The holosystolic murmur could be mitral valve disease. And refer them on, get their echocardiogram. That's going to be the thing that's going to save their life. They did not give us more information about hypermobile joints, easy bruising, stretchy skin, to be able to make a good evaluation for Ehlers-Danlos. Williams syndrome would give you short stature and learning problems in the stellate irides. And we don't have any information to suggest an infective endocarditis. All right, skeletal dysplasias. We've talked about achondroplasia. We're going to talk now about cleidocranial dysostosis. Here's the finding: no clavicles. Okay, and then they can also have head shape differences. But when you don't have clavicles, that's the thing that keeps you from being able to play jump rope with your arms and being able to bring them all the way up and over and around. So you can take these people and take their shoulders and push them all the way into the middle. Everybody has watched Stranger Things. The young man on Stranger Things has cleidocranial dysostosis, and they wrote it into the storyline. So if you watch, like, I think the first episode, you can watch him do the trick whenever they're being bullied, which is bad. Okay. It's autosomal dominant due to a mutation in the RUNX gene. Abnormal skull bones with delayed closure of the anterior fontanelle. Absent is helpful, but they could be hypoplastic clavicles, so they may have some remnants there. Teeth anomalies with late or absent dentition, and short stature. All right, sequences and associations. So these are things that don't fall under the syndrome rubric. So syndromes we know are all due to the same thing. When we have sequences, it's a series of events, and associations are collections of findings that are highly variable and may be due to a variety of underlying conditions. The most common association that we work up is Vactoral association. So anything that has these acronyms are likely an association. So vertebral anomalies, anal atresia, cardiac defects, TE fistulas, esophageal atresia, renal anomalies, radial dysplasia, and limb anomalies. So you call me because the kid has a TE fistula. I'm going to get a spine x-ray, a cardiac exam, make sure that the ins and outs work. All orifices must work before you go home. So if you've got a TE fistula or an esophageal atresia, make sure you also don't have anal atresia. Get a renal ultrasound, look at the limbs. Again, this can overlap and look like, or Fanconi's can look like Vactoral. So this is a rule-out diagnosis. But when you see one of these things, you go looking for the whole component. Sporadic, and nothing else explains what's going on. So you need a normal karyotype, is how the old literature is written in this day and age. It's a normal chromosomal microarray. I often will get, depending on the presentation, breakage studies to make sure it's not Fanconi's. If it's associated with hydrocephalus, it's autosomal dominant. And you need at least 3 off the list to make the diagnosis. And here's the radial aplasia. So again, remember that was also part of Fanconi's. And then you can get vertebral anomalies as well, TE fistulas, the anal atresia. And that's usually when we get called, is when there's GI atresias. Klippel-Feil anomaly is a defect in formation or segmentation of the cervical vertebrae. Most common is C2 and C3, but it's a spectrum of deformity, a fusion of 2 vertebrae to the entire C-spine. Characterized by this short neck and a low posterior hairline. You'll have decreased cervical motion because you have fusion in the C-spine. And fewer than half will have all 3 signs with the short neck, low hairline, and decreased cervical motion. When it's only 2 of the vertebrae, often we pick it up as an incidental finding in an otherwise healthy person. Can also be part of another syndrome or just an isolated segmentation defect. Amniotic bands, whenever the amnion comes apart and we don't understand what causes that, can make strings going throughout the amniotic fluid, and then that can wrap around body parts. So depending on what it wraps around depends on the malformation that you get. So you can get congenital amputations, to the point where you're just missing complete arms or legs. You could be just missing fingers. I've seen children inhale them prenatally, and then it gives you facial clefting or ends up being a lethal condition because it disrupts the brain formation. Amputation, webbing, and then severe defects like this clefting. Pierre-Robin sequence. Starts out with a small jaw, small chin, the tongue stays up, the palatal shelves cannot close. And so rather than a typical V-shaped cleft palate, you end up with this U-shaped cleft. Some people, the jaw is so small, the tongue is displaced back, they end up getting a trach, until we can do a jaw distraction, bring the tongue forward to keep them from occluding. If it's mild enough, you can also suture the tongue to the lip to hold it forward and in place and avoid getting a trach. We think about Stickler syndrome with Pierre-Robin sequence, and we'll have the ophthalmologist come and do a dilated exam. Any degree of normal vision to myopia is abnormal in a newborn or in an infant. Most babies are hyperopic, so normal vision is still abnormal. Potter sequence happens when you don't have kidneys, so you can't make urine, so you don't make your amniotic fluid. And if you don't have amniotic fluid, you cannot grow your lungs. So these children are born with pulmonary atresia and will die both from lack of kidneys and by not having enough pulmonary reserve. They can also have dysmorphic features because they've been compressed in utero without any fluid and end up with joint derangements as well. So this flattened nose, recessed chin, you can have epicanthic folds, low set ears, the pulmonary hypoplasia, and then the skeletal anomalies. And again, the recurrence risk I give you is for the renal problem, not for anything else that we see on the physical exam, because it's a sequence of events. Once you didn't make the kidneys, you didn't make the amniotic fluid, everything else is downstream from that. Pinot-Choquer was a phenotype to begin with, also called fetal akinesia. We've now found a gene for it, RAPSN gene, and it's recessive. Gives you IUGR, arthrogryposis or joint constriction, again, pulmonary hypoplasia, an expressionless face, neurogenic muscle atrophy, CNS anomalies, and polyhydramnios. You're not able to swallow while you're in utero. Prune belly syndrome has an uncertain etiology. You have a deficient abdominal musculature, cryptorchidism, and urinary tract abnormalities, and can be associated with other anomalies, more common in males. All right. Going back to the nursery, you're examining a newborn infant, and notice that her head always turns to the right and resists movement to the left. You also note that her back does not appear normal. Physical exam, her hairline appears low posteriorly, her right scapula appears to be higher than the left, and you note that the spine does not appear to be perfectly straight, suggesting congenital scoliosis. You get a radiograph of the C-spine, shows multiple level segmentation anomalies in the mid to lower cervical spine. The condition that is most consistent with these findings. And this is what we're looking at, is Klippel-Feil. So that's the segmentation anomalies and the fusion of the C-spine. Cleidocranial dysostosis is missing the clavicles. Noonan's and Turner's both can have the low posterior hairline, but not necessarily the spine abnormalities. And the Pinot-Choquer is the congenital arthrogryposis and the immobile face. Metabolic and hormonal bone diseases. McCune-Albright is a gain of function and a somatic mosaic of GNAS1. You get a polyostotic fibrous dysplasia, cafe au lait spots. So this is the balance for NF1 whenever you have multiple cafe au lait spots. These tend to be large and not as numerous in the coast of Maine, as opposed to the smooth coast of California that you will see in NF1. And the coast of Maine has lots of islands, so I also think of it as a sponge painting. So this is one big one. They have autonomous endocrine hyperfunction with precocious puberty, most common feature in females, adrenal adenomas, and hyperthyroid. Pseudohypoparathyroidism is also known as Albright hereditary osteodystrophy. The most common one is type 1A, or the one that's easiest to pick up. It's the same gene, but it's an imprinting defect now in the GNAS1 gene. And you get resistance to parathyroid hormone. There are 3 forms, 1A, 1B, and 1C. They can have elevated PTH, low calcium, and elevated phosphorus. Short stature, obesity, abnormal teeth, and short metacarpals, and especially a short fourth metacarpal. So you can see these very short fingers. And then hypophosphatasia is an autosomal recessive gene in the ALPL gene, which encodes alkaline phosphatase. So this is a defect in bone mineralization. Various onset can be congenital, which is lethal, all the way to an adult onset where you just have bad teeth. When you pick it up, the kid will have rickets or fractures, so there's some overlap with type 1 OI for the workup of fractures. Failure to thrive, premature loss of teeth, so it may get picked up by the dentist whenever you have a toddler who's losing teeth prematurely, and craniosynostosis. The key here is you have a kid who looks like they have rickets, but they have a low alkaline phosphatase. So that's what you're looking for, is that ALK-phos. But they can have high to normal calcium and normal phosphorus. Vitamin D and PTH are both normal. Hypophosphatemic rickets is autosomal dominant or X-linked. When it's X-linked, the males are more severely affected than the females. And here you can see the rachitic rosary and then the severe bowing that's going on. Their pattern of labs, low to normal calcium, high alkaline phosphatase, because they have rickets. So they're responding appropriately to their rachitic environment, and a low phosphorus. They can have frontal bossing, they will have short statures, and then this bowing of limbs. All right, you go to see a 7-day-old baby for a well child checkup. The baby has a birth weight of 3,000 grams, now weighs 3,100 grams. He's 48.3 centimeters long. Mom reports that she's breastfeeding and the baby seems to be feeding well, and this is her first child. Mom tells you she's taking thyroid hormone for an underactive thyroid, and she needed to take calcium and vitamin D since she was a small child to keep her calcium up. You look at Mom more closely and realize that she is plump. She's short, about 4'10", has a round face and short, stubby fingers. She says that her mom also had short stature and similar problems. She has one brother who has similar problems and a sister who's 5'6" and does not have a problem with her calcium. Of the following, this baby and his mom most likely have. Excellent. So this indeed is pseudohypoparathyroidism. So the short stature, the short fingers, and the multiple resistance with needing the calcium supplements. And if they give you short fourth metacarpal, that's even more helpful. McCune-Albright. So pseudohypoparathyroidism is also known as Albright's hereditary osteodystrophy. So Albright should have taken his name off of one of these two conditions. McCune-Albright gives you the polyostotic fibrous dysplasia, premature puberty, and the cafe au lait spots. Noonan doesn't give you any hormonal problems, and the vitamin D resistant rickets doesn't give you the hypothyroidism. All right, single organ dysfunction, which you will cover in depth in a variety of other lectures, but briefly. Polycystic kidney disease. There is a recessive form and a dominant form. Dominant is far more common, 90% will have that form, due to mutations in PKD1 and PKD2. The recessive form is PKHD1 and has a prenatal and infantile onset. Both have multiple cysts in the kidneys. Autosomal dominant can also have liver cysts, pancreatic cysts, aneurysms. So people with autosomal dominant PKD also have a risk for aortic root dilatation and dissections. So they should be monitored for that. And diverticulosis. Recessive gives you renal failure and its attendant complications, and may also have pulmonary hypoplasia, so with a much sooner onset of findings than the autosomal dominant variety. Nephrogenic DI, X-linked, recessive, and dominant. So it can follow any of those types of inheritance patterns. AVPR2 is the one that's X-linked, AQP2 is recessive and dominant. It gives you polyuria, polydipsia, and failure to thrive. Long QT syndrome, I think they also find a new gene every 3 days. It's autosomal dominant. And also problematic is there's variable penetrance. So even if you have the mutation, if you're at risk for having the condition, you may or may not show EKG abnormalities. So that's why it can be helpful to get the gene mutation to know who's going to be at risk and who isn't. You get a prolonged QT interval, and it makes you susceptible to arrhythmias and can give you sudden death, which we would like to avoid. Cartaginer syndrome is recessive due to multiple genes. Gives you a primary ciliary dyskinesis and situs inversus. So back in the day, before EMRs, we would try to fix this X-ray when you went to hang the X-rays on the light board. You hang it up, and it says it's supposed to be this way, and you go, that's not right. And you turn it around and correct the dextrocardia. It's less likely you will do that now. You get recurrent respiratory infections, bronchiectasis, infertility, and the dextrocardia. All right, 2-year-old girl presents with a history of chronic upper and lower respiratory tract infections. Weight is 15 kilos at the 25th percentile. Height is 97 centimeters at the 10th percentile. Temperature is 98.1. Pulse ox is 96. Physical exam, she coughs intermittently and has mild clubbing. Nasal exam, she has purulent rhinorrhea and nasal polyps. And her X-ray shows dextrocardia. Of the following, the most likely diagnosis. And here the significant finding is that dextrocardia, because up until that point, she sounded just like all of those immune dysfunction, bone marrow problems. But with that dextrocardia, then you're really thinking about cartaginers. CF can look like cartaginers, but you won't have the dextrocardia. And then the primary immunodeficiencies can give you recurrent bacterial and viral infections. Nasal polyps can be just the sinusitis, but again, the dextrocardia, and then she has the clubbing that suggests this has been an ongoing issue. Skin and teeth. All right, Sturge-Weber, isolated, can give you hemangiomas in the trigeminal nerve distribution, macrocephaly, angioma of the meninges, and can develop glaucoma on the side that the hemangioma is on. Ectodermal dysplasia, X-linked recessive and dominant forms with multiple genes, and more than 190 disorders are described that have clinical features that go along with ectodermal findings. But what you're looking for are ectodermal problems: abnormal hair, abnormal teeth, the inability to sweat, and abnormal nails. Tuberous sclerosis is autosomal dominant, about 1 in 6,000 people, 2 genes, TSC1 and TSC2. You can use mTOR inhibitors to shrink the tumors that are associated with tuberous sclerosis. Both TSC1 and TSC2 downregulate mTOR, so if this isn't working, mTOR is upregulated, so you can give them medications to help regulate this pathway. There's marked variability within families. Classic features include the ash leaf spot or hypopigmented macules, so these white spots, the Sjogren patch, which is a thickened area of skin, facial angiofibromas. Ungual and gingival fibromas typically come up with time, and I would see in late teens in adults. The cortical tubers and subependymal nodules, seizures, and infantile spasms. Cardiac rhabdomyomas are often picked up prenatally and makes us think about TSC, and renal angiomyolipomas. Neurofibromatosis type 1 is characterized by multiple cafe au lait spots, freckling, neurofibromas, Lisch nodules, optic gliomas, skeletal abnormalities, and learning disabilities in ADHD. It's autosomal dominant. It's about 1 in 3,000, and about half of patients have a brand new mutation, and the other half have gotten it from a parent due to mutations in the NF1 gene, which is a tumor suppressor that's involved in control of mitosis and cell division. There is an AAP guideline for NF1. Here are the typical cafe au lait spots. These are smooth, the coast of California as opposed to the coast of Maine from McCune Albright. Here's the axillary freckling. No one should have sunspots where the sun doesn't shine. Neurofibromas may be under the skin or on top of the skin. They typically start to come up around puberty. And the Lisch nodules you have to see with a slit lamp, but they're the little bumps on the iris. 4-month-old boy presents with complaints of colic. Mom reports that 4 to 5 times per day he has painful episodes so severe he repetitively flexes his arms and legs simultaneously. He then cries after the episodes. Family history is notable for his mom having a history of seizures starting at 16 years of age. And on physical exam, his growth is normal, and he has 3 ash leaf macules on his trunk. Presentation is most consistent with so this is tuberous sclerosis, and the child is having infantile spasms. In our day and age where we can now record things on our phone, it makes it much more clear what is going on in clinic. In F1, you'd see cafe au lait spots. Down syndrome, you would see more classic facial features. Hypothyroidism could be developmental delay, but not the spots. All right, so high yield. Disorders with AAP guidelines. If there is a guideline for it, make sure you at least read the introduction part where it describes the disorder. Within those, they also have information for routine health maintenance and what you should do at each one of those. In addition, there are ones on sickle cell, fetal alcohol, spina bifida, and the evaluation of adopted children. If somebody has more than one birth defect, developmental delays, intellectual disability, physical features that differ from the rest of the family, or growth problems, think about a genetic syndrome. There's a family history of a genetic syndrome. Certain health problems that seem to, quote, run in the family. And other things to think about. Your head is too big or too small, congenital heart defects, short stature or tall stature, birthmarks, unusual skin, failure to thrive, limb or spine abnormalities, and any combination thereof.